Hello, my name is Adam Kirking. I'm the Director of Operational Performance and Analytics with Imperium Health. Today we're going to provide an overview of hierarchical chronic condition coding and discuss a few tips to help you better capture the medical complexity of your patient. As an initial disclaimer, the contents included in this presentation are for informational purposes only. The coding guidance provided does not replace the official coding guidelines or professional judgment and expertise of the individual performing coding based on a number of factors including, but not limited to, documentation in the medical record, correct application of the coding guidelines, and other industry recognized coding guidance. This training is based on the coding guidance from the official ICD-10 coding guidelines, version 23. Coding guidelines and references are updated on an annual basis, and that could potentially make some of the information presented a little bit out of date. We always recommend that you reference your official coding materials for the most up-to-date information. Imperium Health does not guarantee that the information supplied might not be without defect, although every attempt has been made to ensure its accuracy, completeness, and relevance. Information is intended for use by groups associated with the Imperium Health ACOs. So what is risk adjustment factor coding, or sometimes referred to as RAF coding? Well, it's a CMS prospective risk adjustment methodology to predict the future healthcare costs for a beneficiary, meaning it's looking at historically documented codes to predict what future costs will be. That risk adjustment methodology is applied to every Medicare beneficiary, and CMS categorizes ICD-10 diagnoses by costs associated with those chronic or acute conditions. These chronic conditions are then placed into hierarchies reflecting the severity and cost of those conditions. So an HCC risk score is a measure of the predicted or expected cost that will be incurred by the beneficiary during that calendar year. And hierarchies allow for some stratification, so the most serious conditions might kind of pop to the top even when less serious conditions do exist. Understanding how the 9,000 risk-adjustable codes map to those 83 HCC categories can help to make sure that you're best reflecting the medical complexity of your patients. For instance, the 9,000 codes are not necessarily evenly divided into 83 categories, and the major depressive, bipolar, and paranoid disorders category actually has the most corresponding ICD-10 codes. There are a couple HCC categories that only have a couple ICD-10 codes that actually map to them. And we did a quick sample of about 250,000 of our Imperium Health ACO patients, and the most commonly used condition was diabetes with chronic complications. There were some of those 83 conditions or 83 categories had less than 1% of the patients that would actually map to them. So definitely diabetes with chronic complications look to be one of the most commonly used conditions. And now different categories have different weights. That's not meant to mean we should be trying to document metastatic cancer and acute leukemia on a greater proportion of patients. This is just meant to reflect different chronic condition categories will have different weights associated with them. In addition to understanding how those 83 codes are made up, it's important to understand how our documentation or how that ICD-10 coding that we're doing is going to show up as part of the patient score. For instance, on the left we can see we documented for 3 different types of diabetes related conditions or 3 different types of cardiovascular related conditions. When Medicare does the weighting or the scoring on those patients, they're actually only going to count one of those conditions within each category. So even though we documented for 3 different types of diabetes, those 3 conditions are not going to push the patient's risk score over 1. It's actually only going to be 0.368 just for that diabetic component. The same is true for the cardiovascular or the pulmonary component, where even though we documented multiple categories, Medicare is only going to count 1 for HCC category 85. Understanding the dynamic or even which codes are going to populate into which category is not meant to necessarily cause you to not document something, but as you get to your 11th, 12th code, just hopefully making sure that you're most effective with the codes that you are documenting or capturing on your patient. Now that we've reviewed how those 9,000 codes can map to the 83 categories, it's important to understand the dynamic between those 83 categories, as Medicare places a hierarchy or almost kind of ranks the different categories. And because of that, some conditions will almost kind of like trump or override other conditions. That is not meant to say don't fully document on your patients. It's just a snapshot of when you're trying to best understand or best calculate the risk score on your patients, not every code might be counted equally. For instance, if a beneficiary triggers disease group 135, meaning acute renal failure, and 136, meaning chronic kidney disease stage 5, then Medicare will only count 135, meaning that acute renal failure, not necessarily CKD stage 5. In other words, if you document multiple, Medicare may only count one of those. Another example of that is if you documented multiple types of cancer, meaning a very medically challenging patient that had metastatic cancer, lung and other severe cancers, lymphoma, colorectal, breast, or other sort of internal cancers. The way Medicare will do the weighting, or the way they do the hierarchy, they're only going to count the weight for metastatic cancer and acute leukemia. So the patient's risk score would be, or risk score for those 5 conditions would be 2.654, assuming that they're a age non-dual community-based patient, even though there are 5 different categories that were weightable categories that were documented. An additional component of the risk scores, or trying to best predict a patient's individual risk score, is understanding that there will be slight differences or slight variance between Medicare enrollment cohorts. Now, we typically think of those Medicare enrollment cohorts as our end-stage renal disease, disabled, 65 and over, and receiving Medicaid, commonly referred to as age dual, meaning they're dual eligible Medicare, Medicaid, and 65 and older that are not receiving Medicaid, so aged non-dual. And the average risk score for each of those 4 Medicare enrollment cohorts is actually a 1. So the ESRD patient with a 1.0 might be more medically complex than a disabled patient that's a 1.0, but the way Medicare averages or almost adjusts the weight for each condition, they will set it so that the average risk score for an ESRD patient is a 1, as well as the average risk score for a patient that's over 65 and not receiving Medicare is a 1.0. Just to reiterate, an average risk score patient is a 1.0 within their Medicare enrollment cohort. Up until now, we've talked about ICD-10 coding and how those ICD-10 codes interact with those different HCC categories. When Medicare is determining a patient's risk score, they actually have both a demographic risk score as well as the HCC score. Now, certainly we talk much more about the HCC score because it's more directly related to the activities in the clinic. The other component, though, that demographic score, is going to be based on patient's age, meaning is it 65 versus 95? Is it 65 versus 71? Eligibility status, that Medicare enrollment type, so are they dual eligible, meaning that have they ever had Medicaid, or do they have Medicaid now? Have they ever had the disabled Medicare, or do they have that kind of unique, that sub-model of care, meaning maybe a PACE program or the ESRD care? Or are they living in a community setting, meaning they're at home or maybe in an assisted living, or are they in an institutionalized setting, maybe like a nursing home? Then we go back to the HCC where we're going to think about chronic disease burdens, complete, accurate, and consistent coding, and then how those hierarchies are kind of set up with different severities or different specificities, or even different interactions. So with that, we're going to think about complexity and completeness as opposed to how sick the patient is. A few other documentation types ensure medical record integrity. So always make sure that you never erase, overwrite, or white out anything on the medical record. Now that's how we typically think about like a paper chart. So as you're thinking about an electronic medical record, always just try and make sure we're not deleting things that shouldn't be deleted. That's important just in case we ever get audited. We want to make sure that we have as complete and thorough documentation as possible. Now the documentation must always support the diagnosis code. So your coders are going to be very well trained on specific things, but we want to make sure that they're not making assumptions that can't be directly inferred from the clinical documentation or from just general coding expectations. Now, I always recommend documenting things once a year, because if you don't capture information at least once a year, from Medicare's perspective, it's almost like that condition got better. Kind of like your diabetes might have improved, but some things might not go away. Some conditions are always going to be in remission, but not necessarily go away. And always make sure that your EMR is able to submit, or your billing system is able to submit for 12 diagnoses codes rather than 4 or 8. I know it's pretty common to sometimes see ones that are only able to bill 4 or 8. That may mean that you're doing all the right things, you're capturing all the right information, but it's not being sent to your Medicare clearinghouse, so you're not going to get credit for it. A few more things to think about. Be careful about the use of history of to describe conditions that are actually current or chronic, or ones that are still kind of persistent, active, and ongoing. Also be careful about the use of history of if it's meant to describe a current condition that's in remission. For instance, if it was an addiction that's in remission, that should be described as the remission, not necessarily history of. Don't document a condition as current, although if it's really historically only. For example, if a patient had a history of prostate cancer that's been eradicated in the past, but it presents to the office for an evaluation, examination, the PSA, monitor the testing, we have to make sure that we're documenting that as in remission, not necessarily history of. And then use as much consistency as you can, so that as you're presenting different information, that it can never be kind of conflicting or contradicting. A couple commonly missed codes, and we have a tip sheet that we'll be sending out that has a few more commonly missed codes, is amputation status. And the example of that is oftentimes if it's not captured, the perception from Medicare's mind is almost like it grew back. Artificial openings, depression versus major depressive disorder. So that's one of the things that if you document major depressive disorder, that's going to risk adjust, where simple depression on its own will not. Diabetes as opposed to diabetes with comorbidity. A couple slides back we talked about some of the most commonly used codes. Diabetes without comorbidities will risk adjust, but it's at a much lower rate than diabetes with comorbidities. Hypertension as opposed to maybe hypertension with other chronic conditions. Transplant status, or even making sure that we're best capturing morbid obesity. Protein calorie malnutrition, and always make sure that we're not going to go through a couple examples. The first is a 78-year-old male with type 2 diabetes that's controlled with diet. He's being followed by a neurologist for his kidney issues caused by his diabetes and receives dialysis 3 days a week. The patient has hypertension with CHF that has been in control because of his use of medication. In 2008, the patient had his prostate removed due to prostate cancer and successfully completed all of his treatment. The patient had a urinalysis performed today that showed white cells, meaning that the patient was actually positive for a UTI. So when we're getting ready to code or document this patient, we always want to make sure that we're listing first the reason why the patient came in that day. But then kind of as we work our way down, diabetes with chronic kidney disease is actually going to be a little bit greater weight than diabetes without complications. And if we're documenting chronic kidney disease unspecified, that's not going to carry the same weight as a chronic kidney disease that's linked. For instance, chronic kidney disease that's at 3, 4, or 5 is a risk adjustable condition. Chronic kidney disease that's a 1 or 2 is not. And then making sure that we're documenting end-stage renal disease as opposed to just chronic kidney disease. Hypertensive heart with CKD, so we're able to link those conditions. And CKD stage 5, that's a unique one because it actually links to 2 different categories. Making sure that we're documenting CHF, personal history of prostate cancer, and then dialysis status. So the ones that are circled on the right are actually ones that, because of the hierarchy, will carry the most weight or will be the ones that show up. So we can certainly see that on the right we have a much higher score than we do on the left. The next example is a 68-year-old male with type 2 diabetes, no complications, hypertension, and a BMI of 37.2. This is a unique example where we're going to use the BMI between 35 and 40 with comorbidities to create a diagnosis of morbid obesity. So for this patient, wanting to make sure that we're documenting diabetes with documenting that chronic condition, which captures HCC category 18. Hypertension on its own does not necessarily risk adjust, but documenting that hypertension can help to make sure that we're maybe driving additional comorbidities that can help to increase the impact of the morbid obesity. And then documenting the post-left BKA also will risk adjust at a chronic condition category 189. The third example is a 62-year-old male being seen for mild non-proliferative diabetic retinopathy with macular degeneration. He has type 2 diabetes and takes insulin on a daily basis. He also has a diabetic cataract in his right eye. So on the left we documented just the diabetes without complications, and on the right we documented the diabetes with non-proliferative retinopathy, the diabetes with the cataract issue, as well as the long-term use of insulin. So one of the benefits too, on the right we documented 3 different categories, although because of the hierarchy, Medicare will actually only give us credit for one of those, although thorough and accurate coding is still the best and kind of the gold standard. The fourth example is a 72-year-old male who's being seen for a diabetic checkup. She has type 2 diabetes with mononeuropathy and takes insulin on a daily basis. She also has Crohn's disease. So on the left we have, again, we got a little sloppy and we just documented diabetes without complications, so just quickly documented diabetes. So that's going to risk adjust at a little bit lower rate than diabetes with chronic complications, so with mononeuropathy. Making sure that we're capturing those other conditions as well, or making sure that they're being documented at least once a year. So documenting that Crohn's disease with small intestinal of the small intestine, as well as rheumatoid arthritis of an unspecified site. So making sure that we're capturing these things once a year, it best reflects the medical complexity of our patient, because the decision making as part of treating diabetes is going to be impacted by the Crohn's or potentially the rheumatoid arthritis. Understanding the timing of when you capture a code and when it's going to show up or when you're going to get credit for it from Medicare's perspective is a key part of understanding hierarchical chronic condition coding. So CMS requires documentation in the patient's medical record for any diagnosis. So that's something that we always want to make sure that we have that good documentation, and that must be done by a provider once a year. Now, one of the challenging parts about that risk score timing is that if you document something in July of 2018, so that code is essentially dropped in July of 2018, when Medicare does their final reconciliation based on what happened in performance year 2018, and that final reconciliation is usually released between July and August following the performance year, so for this example between July and August of 2019, that will be that first time that we get the official from Medicare thumbs up, this code has been recognized for the patient. Now when Medicare is going back and doing their final reconciliation for performance year 2018, they will use codes that were dropped during the performance year. And that code that was dropped in July of 2018 is actually going to kind of hang around, and that's going to be the score that's used on the patient or sort of presented to the patient as part of that prospective risk score all the way up until kind of the following summer. So a few takeaways for you as a provider to make sure that you're capturing the best information on your patients possible. Something that we didn't talk about today, but we've talked about in other sessions, is trying to make sure that you have a strong annual wellness visit program. that annual wellness visit is one of the best ways to bring the patients into the clinic to try and see them as part of a healthy visit where you're able to capture as much information as possible. Once you have your well visit program in place, take the time to go through and validate your notes. Try and make sure that you're being as thorough as you can, that your templates are set up the way that you expected, that you are actually capturing the codes that you thought you were, and that you're not maybe dropping a code for diabetes when the patient actually has diabetes with complications. Make sure that you're monitoring, reviewing lab results. That's so important as you're thinking about the GFR and staging chronic kidney disease. Always make sure you're assessing pertinent exam results, pertinent lab results. Be as thorough as you can with your documentation. I always will say be thorough just to prevent any perceived upcharging. Avoid that as much as possible by being thorough and accurate. And then ensure that your EMR, your billing system, can submit for all 12 codes. This is a common thing that you'll see a practice that will work really hard to try and improve their coding, but maybe they're not able to get credit for it because they're not submitting for the appropriate number of codes. And final takeaway is be accurate as much as you can. That accuracy is always key to ensuring that your patients are best reflected of their medical complexity, as well as we're not over documenting on our patients or making them look sicker than they may actually be. We're going to be sending out some tip sheets to make sure that you have kind of both commonly used codes as well as the understanding for the dynamic between those categories.